this first talk on
Yes.
pedicle screws and the tips and tricks around it, my opening salvo is going to be that pedicle screws don't always work. And here are some cases and points where pedicle screws don't really seem to work. And one being, of course, in severe osteoporosis, we've all burnt our fingers when the cortex of the, when the cancellous bone in the, doesn't allow the hold on the pedicle screws. When the anterior column can't be reconstructed, pedicle screws become a poor idea because, especially cases where you want to do a posterior fixation and get out quickly, it's a good idea, not to have a rigid posterior construct. And of course, when pedicle screws begin to fail for a variety of reasons. And in all these cases, what comes to your rescue is a sublaminar wire. Unfortunately, it's an implant that's used less and less. Sadly, it's so because of the lack of technical skills. And here I am to take you through some technical notes on how to use a sublaminar wire in your practice. And all of us should know this. I've seen the top surgeons in the top centers in the world use sublaminar wires as a fallback option, as a salvage option, even today. And it's not okay for a spine surgeon who already is a limited resource surgeon to not be able to pass sublaminar wire, which is such a good age-old implant. It was devised by Eduardo Luque in Mexico many years ago. It's a semi-rigid or an unconstrained implant, which gives you segmental fixation. That idea was new when this wire was actually invented or discovered, or whatever you want to call it. Multiple fixation points which rely on an extracortical hold, which means that the wire goes around the cortex of the lamina, and hence the quality of the bone really does not matter for this kind of an anchorage. It is very stable for pull out. It is stable for bending or translation, but not so stable for rotation. And hence, obviously, it is not a great implant for fixation in the lumbar spine. So if you were to do an L3 to S1 fixation, obviously the sublaminar wire is a poor choice of implants. The indications of the sublaminar wire are multiple, and you can practically use it in all indications. And I come from a time when that used to be the workhorse implant for all surgeries, barring lumbosacral fusions, if you may. The modes of use, of course, the sublaminar wire is not a standalone implant, and the sublaminar wire actually is an anchor. And the anchor then has to marry an implant of the type of spinal loop rectangle, or sometimes rods, or sometimes even plates, right? So let's jump into the technique of sublaminar wiring, because that's really what we're here for. Sublaminar wire, the instruments needed are non-specific. There's nothing special that's needed. As you can see, you just need some needle holders, a good wire twister, maybe a good nibbler. So it's not instrumentation heavy armamentorium, if you may. Typically, if you're using it with a spinal loop rectangle, you would need some rectangle pushers, which are standard instruments. The steps of sublaminar wiring go through the following: exposure, preparation of the interlaminar space, contouring the wire loop, passing the wire actually, and locking the wire, and then contouring the rectangle, the spinal loop rectangle, and then wire tightening. Let's go through each of them separately. And I've got a good pictorial on these, so you should be able to understand this entire process quite compositely. So the exposure has to be wide, because you want to do the interspinous clearance wide also. And eventually, when the rectangle, which is your commonest implant that marries with the sublaminar wire, sits, it needs that kind of a width to sit on. So you want to do a good wide exposure. And the preparation of the interlaminar space has to be your first good step. Now, this invariably involves only taking away the yellow ligament without actually nibbling on the lamina. And this is very important. The lamina, or the cortical undersurface of the lamina, is really where the wire would grip. And if you have bitten into that, the wire will cheese through, and that's not okay. So you want to keep that, keep the inferior cortex of the lamina untouched or unharmed, which means that when you start taking away the yellow ligament, the bites have to be done with soft hands. So if you run into bone, you immediately release and just stick to the ligament. The ligamentum has to be removed from the midline all the way to the sides. And especially in the thoracic spine, where the spinous process actually overlaps, it's a good idea to just flush it straight down to get a straight end-on view of the interlaminar space, just like this picture shows. And when you do that, and remember, the yellow ligament is actually a bunch of ligaments stacked one on top of the other. So you're going to thin them down. And once you thin them down, you come to a place where the final layer of the yellow ligament is seen. And as shown in this picture, it has a nice central cleft. And that's where you start nibbling it off with your rongeur from the midline to the outside, so centrifugally, and go all the way laterally as far as you can till the ligament allows you. And that's how you actually, use your forward punch to take away the yellow ligament. You widen that cleft and move laterally. The wire that we use is a number 20 double contoured wire, which has to be long. It's a 20 gauge wire. It's cold cured. Cold cured wires are important because the standard stainless steel doesn't have a good knotting property. It springs. So the wire is flexible, strong, but not brittle, and the tip is blunt. Now, this is a key step, and each wire has 4 bends. The first bend is actually the tip, and that tip scrapes against the undersurface of the lamina. So when you pass the wire, the tip is the leading eye for the surgeon, and it tells you that the wire is not going here and there, but sticking to the undersurface of the lamina. The second bend, as you see in the picture, is a little convexity that helps the wire bounce off the surface of the dura and helps that tip or the end one actually project out of the interspinous space as soon as the wire passes through. The third bend is where the wire bends and starts becoming vertical, and that bend has to be contoured to the length of the lamina that you're using the wire on. And then the fourth bend is a surgeon-friendly bend where the thumb of the surgeon fits in and then the wire comes out in one loop. This is that third bend. The length of that third bend should be equal to the length of the lamina, which differs from patient to patient and from level to level also. And this is how the wire is passed. Remember, while the wire is being passed, the wire should not bend. Just like when you take a stitch, the needle shouldn't bend. You should pass the wire along the curve of the wire, and hence the wire comes out in its in the single sweep. And once it comes out, once you pull the wires on both ends, so there's no redundant loop left under the lamina, and then you lock the wire down. So even if someone touches the wire doesn't fall back into the canal, as you can see over here. And once that is done, you size your hard shell loop rectangle and spinal loop rectangle, you bend it. After this, you have to thread the wires in a way. I'll take you back to that picture. So there's a blunt end and a soldered end. The blunt end has to be always kept inside and the soldered end outside. You have to basically follow one pattern on both sides from the top to the bottom, and then start twisting the wire normally in the clockwise manner. Whichever way you twist it, it has to be uniform across the table, because sometimes the assistant is helping you. And while doing that, the surgeon's hand should be pulling the wire up, so that while you're actually contouring the wire, twisting the wire, there's no redundant loop, and you can really get the wire all the way down, the loop all the way down to the hard shell loop rectangle. And there's a primary twisting where the loop of the wire, or the looping of the wire, so to say, the knotting, goes all the way to the spinal loop rectangle. Then you cut off the redundant edges like this. So here you can see the the twisted end of the wire has actually reached the rectangle. But when you move this wire north and south, it will still move because it's still not been finally tightened. So the secondary tightening is where you start tightening the wire, or the tertiary tightening, if you may, is when you start turning the wire in a graduated manner or in a deliberate manner, where the looped wire will loop upon itself. And that's when you reach the end of the wire twisting. You trim the wire to about 1 centimeter, and you're left with this kind of a profile. You block the interspinous spaces that you've created using using cottonoids or using gel foams, and then you put your bone graft and twist the wire or tilt the wire back on and punch it to make the trimmed ends get into the graft bed, so that they don't come in the way of any of the drain or of closure. The technical tips or the important parts here are good interlaminar clearance, appropriate wire contouring, a smooth entry, visualize that exiting tip well with a suction, and hold the tip with a needle holder that's used exclusive for this, so it does not slip. Chances of accident are if you've the contouring is poor, if you've pushed the wire in the canal or pulling it out blindly, and of course if you've not locked the wire. So make sure all those are looked after. Here are some great examples of where the sublaminar wire can be used. I understand I'm overshooting time, so I'll rush through this, but some very horrendous cases can be well treated with using the sublaminar wires. And I would say there's almost no place where a wire cannot be used except in pure lumbar fixations. And we've used it extensively for all kinds of cases and have had a very, very happy happy outcome. So that's my bit on sublaminar wiring. All I would say is that you want to use the sublaminar wiring, or you want to know the technique. Even if you're doing fancy fixation techniques, you still want to know how to use a sublaminar wire. I'm available for questions if there are any. So thank you so much for hearing me out. Thank you again.